So let's move on to adult obesity, specifically the percentage of adult population age 20 and older that reports a body mass index or BMI greater than or equal to 30. So BMI is commonly defined as the weight in kilograms divided by the square of the height in meters. So looking at the bar graph, Clark County lies at 30.1%, which is lower than the US average, the state average, and the southern Nevada counties. Lincoln County lies at 30.6%, Nye County at 35.9%, and White Pine at 34%. Moving on to clinical care access. So looking at primary care physicians, the ratio of the population to primary care physicians, Clark County is at 1,760 to 1, which is higher than both the US average and the state average. Lincoln County stands at 2,592 to 1, Nye County at 3,102 to 1, and White Pine at 1,331 to 1, which represents the lowest ratio among southern Nevada counties. Let's continue to look at clinical care access, but now let's focus on dentists. So this bar graph displays the ratio of population to dentists. Clark County stands at 1,593 to 1, which is higher than the US average, but lower than the Nevada average and far lower than the other southern Nevada counties. Lincoln County is at 5,159 to 1, Nye County at 5,339 to 1, and White Pine at 3,155 to 1. So moving on to mental health providers, we're still under the umbrella of clinical care access, and specifically, we are looking at the ratio of the population to mental health providers. So Clark County is at 445 to 1, which is higher than the national average and the state average. Lincoln County stands at a steep ratio of 2,580 to 1. Nye County at 586 to 1, and White Pine is at 287 to 1, representing the lowest ratio among southern Nevada counties. So let's take a look at clinical care quality for flu vaccinations, specifically the percentage of fee-for-service Medicare enrollees that had an annual flu vaccination. We can see that Clark County is at 36%, which is lower than both the US average and state average, but higher than the other southern Nevada counties. Lincoln County is at 34%, Nye County is at 31%, and White Pine is at 29%. Got a few more. So moving on to social and economic factors, high school completion, precisely the percentage of adults ages 25 and over with a high school diploma or equivalent. So Clark County stands at 86.3%, which is lower than both the national and state percentages. Lincoln County is at 86.9%, Nye County is at 86.1%, and White Pine is at 88.3%, which represents the highest proportion out of the southern Nevada counties. Now let's take a look at another indicator under the social and economic factors, child poverty, specifically the percentage of people under the age of 18 in poverty. So Clark County stands at 18%, which is higher than both the national and state average. White Pine County has the lowest percentage among southern Nevada counties at 12.6%. Nye County is at 22%, and then Lincoln County is at 16.7%. So let's turn our attention to single-parent households, more precisely the percentage of children that live in a household headed by a single parent. Clark County is at 29.2%, which again is higher than the US and state average. There's a theme here. So White Pine County has the lowest proportion out of all the southern Nevada counties at 10.5%. Nye County is at 27.3%, and then Lincoln County is at 30%. Moving on to violent crime, specifically the number of reported violent crime offenses per 100,000 population. Clark County stands at 757, which is much higher than the US average of 386 and higher than the state average at 657. Lincoln County has the lowest number of reported violent crime offenses per 100,000, which stands at 39. Nye County is at 167, and then White Pine at 221. The last health factor figure that I'll go over pertains to the physical environment, severe housing problems, precisely the percentage of households with 1 of 4 housing problems. To clarify, if a household has overcrowding, high housing cost, lack of a kitchen facility, or lack of a plumbing facility, it will meet the definition of a housing problem. Clark County has the highest percentage in the state at 19.5%. Also, Clark County is higher than the US average. Lincoln County is at 10.3%, Nye County at 13.8%, and White Pine at 9.3%. And so let's switch gears a little bit and talk about how to take action and improve health. On the County Health Rankings website, you can find strategies that work. There's guidance for setting a plan in motion and resources to help you partner with others. So I encourage you, if you want to get involved, if you choose to learn how to take action, discover what works, and who to work with. You can go on the County Health Rankings website and then click on the appropriate links there. So what you see here, this is the County Health Rankings model, and it illustrates how upstream policies and programs can influence public health outcomes, including the length of life and the quality of life. So if you visit countyhealthrankings.org, you can explore the model. And so exploring the different health factor areas like social and economic factors, you can browse the different measures in health in each county. So it's very, very interesting. So I encourage you to explore Clark County and see where we stand. So this next slide illustrates all the different public health system partners there are and how they are connected to the local health department, such as the Southern Nevada Health District. Public health system partners include fire and rescue, corrections, nursing homes, public transit, drug treatment, and more, as seen here. So the local health department is at the center for many, many different partners. And so if you want to explore the 2022 rankings, you can click you can go to the countyhealthrankings.org website. So we'll go into the new features for 2022 in a couple of slides. So for this year's community health rankings, there are new measures included, which is very, very exciting. So I'm excited that these new data are being brought forth. They introduce new opportunities to focus attention and measurement on factors that will contribute to the equitable recovery by supporting the ability of individuals, households, and communities to meet their essential needs in a dignified way. Health equity is a big push in 2022. And so, like what I was saying, there are new data measures in 2022. County Health Rankings have added six new measures, and it's exciting to see what doors these measures will open in relation to equity. So the first new measure is living wage. A living wage refers to the hourly wage needed to cover basic household expenses like childcare, transportation, taxes, medical, food, and housing. It doesn't reflect emergencies or vacations, just basic expenses. This living wage, so there's a living wage estimate calculator, which you can find on the website. So this was created by Dr. Amy Glassmeyer and colleagues at MIT, the Massachusetts Institute of Technology. So once you go on the website and click on your state, it'll show all the county's hourly wage needed to cover basic household expenses, plus all relevant taxes for a household of one adult and 2 children specifically. So it's very interesting. Continuing the conversation, another new measure that was added with the gender pay gap. This refers to the ratio of women's median earnings to men's median earnings for a full-time year-round worker, presented as cents on the dollar. So a gender pay gap persists across industries in the United States, with women earning an estimated 80 cents for every dollar a man earns. So this measure is important because many households are headed by women. The ability of these women to cover their household expenses does impact the economy. Larger gaps in pay and gender inequities are associated with worse mortality outcomes, poor self-rated health, and increased disability. So eliminating the gender pay gap could significantly reduce poverty, especially among single female-headed households. Another new measure is the child care cost burden. So this refers to the child care costs for a household with 2 children as a percent of median household income. So if I can say this another way, how much of the paycheck is being eaten up by childcare expenses alone? So childcare centers, like I said, is the 4th new measure, and this refers to the number of childcare centers per 1,000 population under 5 years old. So speaking to both childcare cost burden and childcare centers, these new measures 3 and 4. So when childcare is affordable, and accessible, it can increase opportunities for parents or guardians to pursue further education or participate in paid work to earn income, in some cases gain healthcare, retirement benefits. Research has shown that in addition to supporting economic security for families, access to high quality childcare contributes positively to a child's health and development and can provide lifelong benefits. So I got 2 more slides here. The 5th new measure in the county health rankings is school funding adequacy. So this refers to the average gap in dollars between actual and required spending per pupil among public school districts. Required spending is an estimate of dollars needed to achieve U.S. average test scores in each district. So as we all know, increased school spending can improve student health outcomes in a variety of ways, such as reductions in class size, increase in the number of adults per school, the amount of instructional time, teacher salaries, which results in more highly qualified teachers. So it's a win-win for everyone. Okay. And the 6th and final new measure is school segregation. So this is defined as the extent to which students within different race and ethnicity groups are unevenly distributed across schools when compared with the racial and ethnic composition of the local population. So the index ranges from 0 to 1, with lower values representing a school composition that approximates race and ethnicity distributions in the student population within the county, and higher values representing more segregation. So again, I go over these measures. This is something that you can go online to explore, to see where your county stands, to see where Clark County stands. But this is these measures are very beneficial to the county health rankings because it really it tries to address health equity and it greater serves the population here in Clark County. So that's everything that I have to say. I will turn it over to the next speaker.
Wonderful. Thank you so much, Brandon and Ben. Join me, for those of you in the room and online, with a round of applause. Thank you both so much for walking us through the snapshot of data for both our community and the new things that are happening at County Health Rankings. I am especially struck by many of the new indicators for health equity and excited to hear what discussions and areas of opportunities they might present themselves. Sorry for people online, I move too much when I talk at this mic. I'd like to introduce our next speaker. So our next speaker is a rising star, Carmen Hua. Carmen is a health educator at the Southern Nevada Health District in her hometown of Las Vegas, Nevada. And in this role, she currently coordinates the Community Health Assessment and Community Health Improvement Plan. She holds a master's in public health, as well as a bachelor's of science in community health sciences and gerontology from the School of Public Health at the University of Nevada, Reno. Help me welcome Carmen. Thank you.
Thank you so much, Jessica, for that wonderful introduction. Good morning, everyone online and in person. I saw that we had 60 people joined us virtually earlier. So thank you all for joining, and everyone in person today. I counted about 15 of you guys. So grateful for everyone to be here today. So as Jessica has mentioned, my name is Carmen Hoy. I am here to give an update on the community health improvement efforts in Southern Nevada. Okay, so I just wanted to do a brief overview outline. So I wanted to go over the MAPP framework, the 2020/2021 Community Health Assessment that was released last year, the Community Health Improvement Plan efforts that's currently going on, and a brief SNHD accreditation update. Okay, so to start off with the MAPP framework, so what does that even stand for? There's so many acronyms in public health, right? The MAPP framework is mobilizing action through planning and partnerships. So this was developed by NACCHO, National Association of County and City Health Officials. So this framework is a community-driven strategic planning process that really aims to improve community health. So in this formal assessment, it was adopted by the Community Health Assessment Steering Committee. So there were 4 assessments. So in the outer circle, there are the 4 assessments. So the first one is the Forces of Change assessment, the Community Needs and Strengths assessment, Local Public Health System assessment, and lastly, the Community Health Status assessment. So this is the phase where we organize for success and develop partnerships and create our vision. So after that is done, we created the community health assessment. So you can actually download the full report on healthysouthernnevada.org. So let's see. The community health assessment, we really try to focus on the key health needs and issues that our community has through data collection and analysis. So this report helps identify the community's health-related needs and strengths, as well as our resources to address and improve our health outcomes. So SNHD, we collaborated with so many organizations and conducted this CHOP. So this intended purpose was really to provide the overview of health information, as well as seeking to identify target populations, as well as who may be at an increased risk of poor health outcomes. As there were many threats and opportunities, strengths and weaknesses, and health indicators identified in the CHOP, I will just be going over a few from each assessment because there are many. But if you wanted to look at the full report, 163 pages on healthysouthernnevada.org, please check it out. So the first assessment, the forces of change assessment. So a key threat, so this assessment actually focuses on identifying forces such as legislation, technology, and other impending changes. So the first threat that was identified was actually unemployment. So this was a topic of economic force. So this really impacted the whole state as a whole, and it was a hard hit to Clark County, and it resulted in a result of COVID-19. So this was a threat and concern, and it actually resulted in a higher number of uninsured Nevadans. And an opportunity in the forces of change was actually an increase of number of providers. So this will help with aiding more access to healthcare in the community. And as we go on to the next assessment, the community themes and strengths. So this assessment helps provide a deep understanding of issues that residents feel are important. So the strength that was identified was the community supports a healthy lifestyle. So there was actually an increase in options for nutrition and physical activity, but participants stated that there could be a use of more services as well as resources and information. As for a weakness, so it's access to healthcare. So the availability is not the same as accessibility. So that's my favorite statement. So we also take into consideration of the cost versus access, as there's various aspects of low quality health care in addition to mistrust. And for the third assessment, the local public health system assessment, this assessment here focused on the organizations and entities that contributes to the public's health. So a strength identified in this assessment was collaboration and community partnership. And participants in this assessment stated that there's currently good spirit of partnership and coalition amongst the local public health system and recognize the multiple strong partnerships. As for the weakness, there is a lack of funding. So this has been consistent throughout all of the 10 essential services, and the lack of funding created staffing shortages as well as reduces services in Southern Nevada. And lastly, the community health status assessment, our large bulk of the report. So this was the assessment that really collected, assessed, and reported on all the health indicators about the health of our residents, as well as enabling identification of health issues. So we collected data from 2014 to 2018 to show change, and 2016 to 2018 to show averages. So there were a total of 67 health indicators, and of those, 51 were reviewed by zip code. So there will be zip code maps attached into the report. And so this specific assessment right here actually ties into our county health rankings presentation today, because some of those health indicator data was actually utilized directly from those rankings. So great resource. All right, and then we have our next slide. So I wanted to show everyone our top 5 zip codes with the greatest health burdens. So this is actually in the back of the community health assessment report as well, with actually every zip code listed with health burdens. So please check that out. The top 5 is actually located in downtown region of Southern Nevada. So this really helps with the snapshot to see our target populations according to the data. So many health burdens actually consisted of chronic diseases, which actually demonstrates the targeting with more specific policies as well as programs to ensure there's reach in specific populations. So in chronological order right here, I wanted to tell you how many health burdens each zip code had. So 89030 had 18 total, 89101 had 25, 89106 had 19, 89115 had 12, and 89169 had 14. So out of the 61 that were identified. And some examples include hypertension, access to care, obesity, and poverty. And then this slide right here, I wanted to go over, in case if anyone has missed our meeting, I wanted to talk about the key data intersections that were identified in the CHA report. So the CHA coordinator and steering committee all gathered and identified these key data intersections, but we did have our prioritization meeting back in October, and the community members have decided on top 4 priorities, which I will get to in a second. But these were the 6 key data intersections. So access to care, mental health, community safety, chronic disease, transportation, as well as funding. All right, so you saw this slide already, but we are going into the CHIP portion, so the Community Health Improvement Plan. So this is where we are currently standing in the process, and we have a fantastic, robust, and passionate group of steering committee members a part of the process right now. They are working so hard in forming strategic issues, goals, strategies, and an action plan to implement all these great ideas to make a change in the community. So I will get into that. But before I get there, I wanted to go over how health equity and the CHIP tie into one another. So MAPP, the framework, it's actually undergoing an evolution and is promoting equity as a new foundational principle. So how does this apply to the CHIP? Well, it actually helps develop a collective vision for success, builds relationships and trust with the community, as well as understand our current community resources, as well as re-engage conversations about what success would look like to achieve health equity. So as we can see here on this slide, equity, community engagement and collaboration, inclusion, data and community-informed action. These are just a few foundational principles, but some that I really wanted to highlight. So these will be focused on in the Community Health Improvement Plan. And to go back, I wanted to share with you all the current priority areas that were chosen at that prioritization meeting. So in order, it was chronic disease, access to care, transportation, and funding. And then to go back on an update on the Community Health Improvement Plan, I wanted to share the steering committee update. So just really emphasizing on the amazing community engagement from all these members listed and their respective agencies. So currently we're standing at 26 steering committee members, but we are still recruiting more if anyone wants to join. So there's varying agencies, lots of collaboration and engagement going on. And the update and process that it's currently undergoing is, so for the past few months, every meeting that we've had so far, there has been long discussions, long meetings to go over what goals can be met, what objectives have been identified, outcome measures that are expected, and intervention strategies that can help with implementation. So I just need to emphasize that the CHIP could not stand without all of these amazing people and community partners. So just wanted to say that it's very community driven, and I would be so happy to see if anyone else would like to join the process. And to tie that into our goals for the Southern Nevada Community Health Improvement Plan. So at our first meeting, we actually decided and went over what our goals are for and the vision for what this CHIP report wants to be. So as we all brainstormed, this list provides us a foundational goal for this plan. So it really emphasizes on equity as well. So to go over every point, just really reflects on inclusivity, opportunities to improve community health, It has a clear roadmap. It addresses root causes of health issues and inequities. It utilizes data to increase impact on strategies, which is really important. And lastly, it ensures the chip will be health inclusive of health equity for all populations. So this is the foundational goals for what the steering committee and I have came up with and what we will be implementing in the community health improvement plan. So might be wondering what's next. So we're still going to continue our community health improvement plan process with our community partners. It's a very important process and cannot do it without everyone. And then we will also continue to engage our community partners for collaboration and implementation. There's still so much to be done in the community, but if we all work together, we can see change over time. And then lastly, we are currently, the undergoing of developing the CHIP report will most likely come out this fall of 2022. So look forward to that. And then my really quick update, as you may or may not heard, but you know now, on March 16, the health district announced that we are officially accredited. So yes. Huge accomplishment. So Health District is the third department in the state of Nevada to be granted accreditation. It's such a huge milestone, accomplishment, and the recognition of the Health District's commitment to protecting and promoting public health in our community. So it's just huge. So just wanted to put that out there. And then my next slide. So this wraps up my presentation, and I just wanted to thank everyone here for tuning in today and see how valuable each and every one of you are in our community in helping us making Southern Nevada a healthier and stronger place. But if you had any interest in joining that CHIP committee, my contact information is on the screen right now and would love to hear from you. But thanks, everyone.
Thank you so much, Carmen, for your presentation. This work never ceases to amaze me. I hope some of you will be inspired today or online to join Carmen's CHIP committee, don't try to say that 5 times fast, to help make a difference in Southern Nevada. And I was glad to hear you all give it up for accreditation. We're so proud of that. Next, I'm excited for you to hear from Xavier Foster. Xavier's public health experience ranges over 10 years, including facilitating evidence-based curriculums, program development, implementation, and management. He currently serves as the Health Equity Coordinator for the Southern Nevada Health District. Help me welcome Xavier.
Thank you, Jessica. As Jessica stated, my name is Xavier Foster, and I am the Health Equity Coordinator here at SNHD. So this morning, I will be taking a brief few minutes to just provide a funding overview, the work that we are doing with our partners in the community, the Health Equity Program overview, and some of the activities by the Health Equity Quality Improvement Work Group. So in June of 2021, SNHD was awarded around $22.6 million by the CDC to implement the national initiative to address COVID-19 health disparities among populations at risk and underserved, including racial and ethnic minority populations and rural communities. Under this funding, we are implementing four strategies in the community. The first one is resources and services, which activities include the expansion of testing services, connection to services for high risk in rural communities. Strategy number 2, which is data and reporting, which activities include the improvement of data collection and reporting. Strategy number 3, which is led by the Health Equity Program, which activities are focused on building, leveraging, and expanding community capacity to provide equitable access to COVID resources and services. And the 4th strategy, which is the partner mobilization, which activities include the development of culturally appropriate educational and informational campaigns. So strategy number 3 was awarded around $5.5 million. And through the request of proposals, we were able to recruit 11 community partners listed in this slide in no specific order. And the organizations range from LGBTQ serving organizations to small community-based programs. The work of our partners has included providing education, conducting outreach events, as well as hosting testing in the vaccination clinics. Part of the strategy, which was infrastructure support, we have been able to assist with COVID-19 plans and health equity plans to support communities that are most at risk. We were able to establish health equity positions here at the district as well as in the community, and we've been able to build and expand the community's capacity to address COVID-19. So now we'll talk a little bit about our program. So it was established in June of 2021 with the funding of CDC, and we were able to fund the health equity coordinator positions and 3 health educators. Under our grant activities, the health educators act as liaisons to our community partners and provide support for outreach and testing events and participate in community coalitions such as Está en tus manos, and also providing technical assistance to grant participants. Under the program activities, our team collaborates with other SNHD programs to provide technical assistance to help them tackle health equity issues. They also conduct outreach. And for the last 6 months, the team has worked to build SNHD capacity to address health inequities by developing workshops and providing technical assistance. In addition to the health equity programs, the Health Equity Quality Improvement Work Group was established in January 2018 and is formed of a cross-sectional team of SNHD staff. Some of the activities that they have conducted since was the implementation of an organizational self-assessment using the tool by the name of the Bay Area Regional Health Inequities Initiative. Some of the steps that have been completed during this assessment include a staff survey, which was used by the organization to get a wide picture of the attitudes, practices, competencies, and structures that indicate the capacity to address root causes of health inequities and identify priority areas. We also did a collaborating partner survey, which provided us an opportunity for other agencies and organizations that work with SNHD to share their feedback and insights regarding the health equity work that we have been doing in the community. We conducted staff focus groups, which were used to gather information with more context about the elements measured in the staff survey. We also conducted management staff interviews, which provided more in-depth information about the matrices that were measured in the staff survey. And lastly, we did an internal document review, which provided the opportunity for identifying priority areas through review of the existing documents and materials, and to see the level of responsiveness of our HR system in serving a diverse population. With this information that we gathered, our next steps are analyze the data, provide a presentation to SNHD leadership, and then to the Board of Health, with the hope of using the information that we gather to keep working on increasing the capacity of the organization to provide health equity. Since we have, as a program, we only been in place for 6 months, and we have been focusing on COVID health equity. But as we move past that, our next steps are to go into the community and start engaging the community and get more partnerships and continue to provide technical assistance and resources to SNHD programs. Funding is always important, so we are searching and seeking funding, whether it be private through the Robert Johnson Foundation or future federal grants. Thank you.
Thank you so much, Xavier. We are so grateful, Xavier, for your leadership and dedication to health equity and at the health district and in the broader community. Thank you. Finally, it's my distinct honor to welcome our final speaker, a true public health hero, Maria Azzarelli. Maria joined the Health District's Office of Chronic Disease Prevention and Health Promotion's tobacco program in 1999. So you heard that right, over 22 years of service to our community at the Health District. And she was wisely promoted to department manager of the Office of Chronic Disease Prevention and Health Promotion. Throughout her career, Maria has participated in the development of numerous grant applications that have resulted in over $25 million in funding to the state. She's dedicated to reducing health disparities and advancing health equity. In 2017, Maria was nominated and elected into the UNLV chapter of the Delta Omega Honor Society, which recognizes outstanding achievement in the field of public health and reflects the dedication of an individual to increasing the quality of the field and protection and advancement of the health of all people. In 2018, Maria earned the Nevada Public Health Association Leadership Award. She was certified as an advanced high Spanish language oral proficiency by the American Council on the Teaching of Foreign Languages and has been a certified health education specialist since 1999. Please help me welcome Maria.
Thank you. It's wonderful to see so many of you in the room today. As you heard from the presentations earlier this morning, health equity and how we can put it into practice has become more of a focus in the rankings dialogue and really in the dialogue in all of our society. I think the pandemic really heightened awareness of what health equity is and health disparities. I'm going to share how we work toward health equity in the Southern Nevada Health District and of course in the Chronic Disease Prevention Department as well. When I talk about this, we cannot do this alone. This is true partnership with the community. And so I just want to make that very clear that none of this is done just us. It's really incredible partners out there that have been dedicated for decades to doing this type of work. So now that you've seen the data, we'd like to share some of our ongoing efforts to reduce the burden of chronic disease specifically and to work toward the achievement of health equity. As you saw from Carmen's presentation earlier, chronic disease is the first focus area of the Community Health Improvement Plan. So just to go over what chronic disease is, I know we throw around these terms a lot, but I just want to define it a little bit better. You know, chronic diseases are broadly defined as conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living or both. Chronic diseases such as heart disease, cancer, and diabetes are the leading causes of death and disability in the United States. 6 in 10 adults in the U.S. have a chronic disease. 4 in 10 adults have 2 or more chronic diseases. And of course, chronic disease is the leading driver of the nation's $3.8 trillion in annual healthcare costs. In Clark County, chronic disease has continued to be among the top 10 causes of death. And of course, tragically, among Clark County residents, different groups show higher rates of certain diseases. And we don't have time today to go into all of the diseases and the rates amongst different populations, but sometimes it's very, very stark contrast. One population is devastated by a disease more than the other. But I do want to delve into what we're trying to do to address that. And oftentimes when I talk about the populations that are more burdened by chronic disease, we're talking about low-income populations. We're talking about African Americans and Hispanics as well. And you'll notice a theme in some of the projects that we work on that we focus projects on those populations specifically. So when we talk about chronic diseases, it's important to talk about the short list of risk factors that contribute to so many chronic disease. And I like this graphic that I borrowed from another community because it really shows the link. So first, tobacco use and exposure to secondhand smoke, unhealthful diet, including diets low in fruits and vegetables and high in sodium and saturated fats, physical inactivity. And we focus the work in my department in the tobacco area, unhealthy diet and physical inactivity mainly. When we talk about chronic diseases, and you saw this reflected in the county health rankings presentation, we must address the social determinants of health. And social determinants of health refer to non-medical factors such as employment, income, housing, transportation, childcare, education, discrimination, and the quality of the places where people live, work, learn, and play. They have a major impact on people's health, well-being, and the quality of life, and they, of course, contribute to wide health disparities and inequities. So, for example, people who don't have easy access to a grocery store with healthy foods are less likely to have good nutrition. That raises their risk of health conditions like heart disease, diabetes, and obesity, and even lowers life expectancy relative to people who do have access to healthy foods. And in order to advance health equity, public health must work across many sectors so that we can address these social determinants of health. We can't do it alone. So I think sometimes there's a misunderstanding of what health equity means. So I wanted to include the definition provided by the Centers for Disease Control. So I'll read it aloud. Health equity is achieved when every person has the opportunity to achieve their full health potential, and no one is disadvantaged from achieving this potential because of social positions or other socially determined circumstances. So you may notice in my verbiage that I use here, I say we're attempting to reach health equity because this is very big. This is a very big thing to achieve. So we're always trying. When you achieve health equity, each person has a fair and just chance for optimal health. It involves acknowledging that each segment of our population has differing level of disparities. So these disparities are eliminated by uplifting everyone to the same playing field. And the graphic there, I think, shows that. And for equity, to achieve health equity, the obstacles for health unique to each group are removed. So for example, lack of housing, lack of healthcare access, poverty, discrimination, giving the people the tools to they uniquely need to have a fair chance. And in the work that we do here at the Southern Nevada Health District, our purview is very large. So we work less on the individual level and more on the population health level. And so we try to work with population groups to give them what they need to help them achieve health equity. And health equity has to be built into every component of an organization. And as Xavier mentioned, Southern Nevada Health District is more committed than ever to demonstrating that through the development of the health equity team. So what we do in our office and how we do it is we try to create communities that support healthy lifestyles through policy, systems, and physical environmental improvements. We plan and implement programs designed to encourage healthy behaviors. We develop partnerships with community organizations to make it easier for residents and visitors to engage in healthy lifestyles. We promote and support behavior change and link people to available resources. And we seek grants and other funding opportunities to support implementation of evidence-based strategies and activities. This last bullet here, Xavier mentioned, that Southern Nevada Health District was awarded grant funding to address COVID inequities. And we in our office are constantly striving to attract grant funding so that we can do the work that we do. The issue with grant funding is that you are really beholden to the grant funder and what they say you can do with those funds. And sometimes there are extreme restrictions. And so I want to lay that out before I show you some of the real life applications of all of this. So this is some of the real work that's going on in our community to address health equity. So we do many things out of our office, but these are some prime examples that I think that really show the elements of health equity. So first off here, we have the Barbershop Health Outreach Project. This is a hypertension and prediabetes screening project. We also offer education and referrals. And the reason that it's called the Barbershop Health Outreach Project is because it is conducted inside barbershops here, African-American owned barbershops, and we work with 10 barbershops currently throughout Clark County. And for this project, the focus is African-American men. And going back to the partnership statement that I made earlier, we are working in people's businesses with this project. So this is a very delicate balance. It took years of relationship building in order for us to be able to go and do this, not just amongst the barbers themselves and have them be our advocates and our influential messengers to their clients, but we also work with the clients as well. a great component of this project is that when we do a screening and someone has an elevated blood pressure level, we work with, to refer them to healthcare to, again, bridge that gap and provide access to care for people. So we try to go through the whole continuum. That project was very successful and quite popular, so we wanted to expand it to the beauty salons. And so we have some grant funding. Again, these are all grant funded projects to do the same thing, screening, education, and referrals in beauty salons that are Black owned, and that the focus of this project is African American women. Some more examples of the work that we do, and this is going on right now, so you may be able to see this or hear about this in our community, is the pop-up produce markets. With this, we work with the Veggie Buck Truck, and we provide low-cost, fresh, regionally grown produce. We accept SNAP benefits, also known as food stamps, and EBT, and we participate in the federally funded Double Up Food Bucks Nutrition Incentive. And so we partnered with the RTC on this, and so the Veggie Buck food truck will go to the Bonneville Transit Center and appear here at the Southern Nevada Health District over the next few months. And as a matter of fact, next week we have an event at the Bonneville Transit Center on May 4th, if I'm not mistaken. And this is a great opportunity for people to access fresh fruits and vegetables, particularly those who have limits on transportation. So we make it convenient. We also have a project called the Supporting Wellness at Pantries program. This is a nutrition ranking system that identifies and encourages healthier option in food pantries. And we provide equipment, materials, education, and technical assistance and training for the entities that are participating. So we're working with 6 faith-based food pantries. 2 of these are primarily serving the African American community, and 2 serve the Latinx community. And the priority populations for this project are low-income individuals as well as Spanish-speaking individuals. Again, helping access healthier food options. Next here, we're working with the RTC again on the reduced fare bike share pass program. So we offer discounted bike share passes for SNAP or food stamp recipients. And this again allows increased access to food retail and everyday destinations as well. And again, this is helpful for those who are transportation limited and low income. We also work to help people with diabetes manage their diabetes. So we offer the diabetes self-management education and support classes. These are evidence-based. They are free, of course. And these are for adults, offered in English and Spanish, but we also have done work with youth as well during summer camps. And we conduct these in person and virtually. And our priority populations for these projects are uninsured or underinsured and high burden populations. We also work on the Faithful Families Project. This is an evidence-based nutrition and physical activity education program taught in the faith-based setting. And we work with promotoras, which are community health workers essentially, but they're Spanish-speaking. And they're trained to co-teach lessons in places of faith. And this is also an excellent program where we rely on our faith community partners who let us in to conduct these interventions amongst their parishioners. Again, it takes years of work to develop those partnerships. Now we're going on to our tobacco control program. What we do, a great example is to expand smoke-free policy. And so we do this in a variety of ways. So first off, I'll talk about our smoke-free housing initiative. Earlier in the presentation, Carmen highlighted 5 zip codes that are prioritized because they have a large burden. We also work in those 5 zip codes and additional zip codes. And so we focus on many of our efforts in certain zip codes. And so with the Smoke-Free Housing Initiative, we have secured over nearly 7,000 smoke-free apartment units in our community. And we actually have over 52,000 smoke-free housing units that we've worked toward over the past decade and a half. This is a very big deal because this is where people live. And so we are creating smoke-free environments for them. So our tobacco control program meets with apartment managers and complex owners and provides technical assistance, signage, and all sorts of assistance to help them expand their smoke-free policy. Another example is working in venues such as UNLV. You may have heard that after 20 years of working really hard, UNLV has developed a tobacco-free campus policy, and that was through great partnerships with the university and our tobacco control program working very hard. We also work with the Las Vegas Lights soccer club and the baseball, the Aviators, to develop smoke-free and vape-free facilities. And so this is also a big deal because this is where people go for entertainment and they need to be in a healthy environment. We also work to expand smoke-free policies in businesses. And so while we do this for the whole community, we have a specific effort to focus on those zip codes that were referenced earlier. And so we work with 22 minority-owned businesses in those priority zip codes to expand their tobacco policy. And what that means is we do have a state law that says no smoking or vaping indoors, but there's nothing that contemplates the outdoor area. So we work to expand into the doorways. So those are called minimum distance policies where you say, no smoking or vaping within 15 feet of this entrance, things of that nature. And I should say that there are exclusions. There are businesses and entities that are allowed to continue to smoke per Nevada law. So we work with them to voluntarily go smoke-free. And those are huge successes when that happens. We work to promote tobacco cessation in many communities. So to do that, we've developed throughout the years specific branded campaigns and programs. And so for the Latin community, we have the Por Mí, Por Ti, Por Nosotros program. In the African American community, we've developed the Because We Matter project. For the LGBT, and of all of these listed here, this one has been around since 2005. We have the Crush program. And then for the Native Hawaiian and Pacific Islanders, we work with our Island Envy program. And so how we promote cessation, here's an example. In the African American community, this May, we're working on the No Menthol May project, and we're working with 8 participating churches who are working with their parishioners to pledge to go smoke-free during the month of May and to also implement no tobacco policies on the church grounds as well. And so that's just one example of how we do that. And then we work with our state tobacco program to secure free nicotine replacement therapy for priority populations that choose to quit smoking. And so that's a big deal because that's a cost savings and it's providing access to cessation therapy. And then another way that we work with these priority populations is to reduce exposure to targeted tobacco industry advertising. And we have 3 events listed here: the Cinco de Mayo Festival, the Juneteenth celebration, and the Las Vegas LGBTQ Pride festivities that are going to be happening. And our tobacco control program worked with all of the organizers of these events to assure that there are no tobacco advertisements present at these events. And why I say that, you might think, well, does that happen? It sure does. Tobacco industry will find a way to promote their products at these community events. And we've even seen things like, cigar sampling and hookah lounges set up outside throughout the years at family events. So we work with the organizers to assure that that doesn't happen. And also I don't know if I just said this, but we make sure that there's no tobacco use allowed at the event itself as well. And then the Centers for Disease Control really was a fan of the work that we were doing, particularly like with the barbershops and really prioritizing these priority populations. So they provided us some funding to work on COVID flu vaccine promotion among these populations. This is separate from the funding that Xavier talked about and separate than the other funding that was received by the Southern Nevada Health District. So our charge with that funding is to work with these populations in the priority zip codes that we've identified, equip influential messengers to promote vaccination, develop communication products, to conduct events to promote vaccinations, to enhance healthcare provider partnerships, and to provide mobile vaccination sites. So we've been working very diligently, again, with community partners to assure that that happens. And it's amazing when you're interacting with the community you can see the difference being made right then and there, particularly with this project, when you can convince someone who was skeptical about a vaccine to get one, and you're providing the service right there. So if you'd like to learn more about some of these projects and more, you can visit our office's website. We have the gethealthyclarkcounty.org website. We keep that up to date with the latest and greatest. And the vivasaludable.org website, which is a Spanish language version of the site. And I think that is all for me. Thank you so much.
Thank you, Maria. So many incredible presenters today. So grateful for that. I'm going to turn it over to Dr. Johnson for some closing remarks, and then we'll have an opportunity for questions. Dr. Johnson, over to you.
Yeah, thanks, Jessica. And I want to thank everybody for their time and tuning in today and attending in person. And really a special thanks to all of our speakers and not just for excellent presentations today, but all the effort they put into this day in and day out. Also want to express support for Dr. Ligon, our district health officer, and our board of health members who really help support a lot of the work that we do in the community. As mentioned, the new data and measures have been released today and are up now on the countyhealthrankings.org. So if anyone wants to check it out. So let me close with that. And again, thanks everybody for attending, and let us know if you have any questions. Thank you.
Great. Thank you so much, Dr. Johnson. And as we wrap up, before I take questions, I just want to thank everyone for joining in person today and online, for learning about the Southern Nevada's County Health Rankings, an opportunity to discuss some public health successes, challenges, and opportunities. I'd like to thank all the speakers. If I could just get one more round of applause for them.
Yes.
So much. Our attendees, again, virtual and in person, the Nevada Public Health Institute for the collaboration, as well as the Trudy Larson Institute. At this time, I'm going to open the floor for questions. So I think Carmen will be reading off any questions we receive online. And then if you are in the room and have a question, I have a dedicated mic for you to ask them so we can ensure the folks online. I don't see any burgeoning hands in the room at the moment. Carmen, do we have any questions online?
No, we do not have any questions at the moment, but I just put a message in, and we'll wait a few seconds to see if anyone has any questions.
Great. I know we're a few slides removed from the data slides, so grateful. And I don't want to stand between you and your coffee or orange juice. Court, just one moment.
So Carmen, I'm not sure if you can answer this question if you've been around previously with the prior challenge chip process, but what did you learn from that prior process that helped inform the current challenge chip process?
So I wasn't here for the previous process, but for this whole process in general, I've been learning so much. There's a lot of trial and error, a lot of lots of learning on the way, tons of engagement with community members, as well as just learning how to adapt to everyone else's schedules and see how we can actually make something work and implement that.
Yeah, I guess my question was not so much to the process itself, and I apologize for not being clear about this, but more towards the identification of the metrics, if you will, the things that you wanted to focus on improvement, and what the success was in terms of being able to make any changes in those metrics. So, for example, if you identified diabetes as something that you wanted to work on, what kinds of measures, what kind of success have we seen with the data during that previous child chip process that would help us understand if we did what we intended to do in terms of trying to make improvements in those metrics, and with other examples as well.
So with the previous process, I know they went off of also the MAPP framework and from NACCHO. So they gathered their health indicators also from county health rankings and other data resources. For my understanding, for example, diabetes, that's a very important topic. We were looking at the past trends and data to see if it has improved or it's something we still need to work on. So just having our epidemiologists assess the data to see if that's something that we want to include. But there's so many other health indicators that were reported in the report that you would find surprising, or you'd be happy that you'd seen it, because comparing to other community health assessment reports, a lot focus on basic health indicator needs, but we try to go more in depth with everything.
Yeah, if I can add to that, if that's all right, I also get the luxury of working with Carmen. I think something that we did this time around that was an area of improvement from the last time around is we did collect additional qualitative data. So something that was interesting, so you'll notice like access to care was a priority before and is a priority this time around, but we know access to care is a large category. So this time around, folks were identifying culturally relevant services, for example, as important for them. And that came out of some of the qualitative data that we were able to gather as part of the report, if that makes sense. Great question. Other questions from in the room, or maybe we have some burgeoning questions online?
I have a question. Let's see. Okay. I think that's a question for me. I just asking how the individual can get involved with the process. I can reach out afterwards, and we're just getting a ton of comments, saying great presentations and great meeting, but not any more questions at the moment. So if anyone has any additional questions they are dying to ask, please put them in the chat box.
Yeah, great. And we can leave the chat box open. We'll be available online as well. And I think the folks in the room would echo the great presentation that was shared here today. We'll get one more round of applause for our speakers. Thank you all so much. Wrap up. Enjoy your refreshments for folks in the room, and thank you all for joining.
Thanks.
Yes.